Awesome. So hello everyone, and thank you for being here. So we're going to talk about I think one of the most important topics for us in the ICU and about sedation and neuromuscular blockade. So these are probably the most common medications that you would see we use in our patients, especially if they have a endotracheal tube. Okay. So when we decide about what medication we need to use, so what are the goals? Can anyone like enumerate a few, like what are you trying to achieve when you want to sedate a patient?
Either pain control or
Yeah.
keeping them away from their tube.
Yeah, so pain control, so analgesia, so make sure that they're safe, so you don't have them accidentally extubate. What else?
Decreasing metabolic demand.
Yeah.
Oxygen requirements.
Yeah, it's decreasing metabolic demand. A lot of our kids, especially with ARDS, sepsis. I mean, sometimes you just have to have them relax and let the ventilator do their stuff. What else?
Keep them from fighting the vent.
Yeah, so and the fighting the vent, and so there's a like a medical term for that. So that's a ventilator asynchrony. So what happens is the ventilator gives us breaths just opposite to how we do, right? I mean, we do negative pressure ventilation. So we suck in air from the atmosphere. That's not how ventilators do it, right? It's positive pressure. So there's a machine that's pushing air in. So when you're awake, it's a different feeling. And it's like, okay, if you set a rate of 20 per minute, no matter what, the ventilator is going to give you a 20 per minute, even if you don't want to breathe that fast or whatever, for example. But at that point, depending on your disease process, you need that. So definitely, there's always this. So we say, oh, the kid is fighting with the ventilator, so you want to keep them sedated. So yeah, you guys, I mean, enlisted most of the important ones. So analgesia is one of the most important ones. Ventilator asynchrony, amnesia. A lot of times, we tell the parents that they may not remember what this happened, and I've seen a lot of like older kids who can communicate once they're extubated. They really don't have recollection of events, like if someone put a line in them or when you suctioned or something. If you give, and we'll talk about specific agents which will do more amnesia compared to more analgesia and stuff like that. Reduce physiologic response to stress. So we talked about that. So those are the goals that we're trying to achieve, and that's anything that's not just for sedation, for any procedure, any medication that we do, or any intervention. I think the question we should always ask ourselves: what is the goal? What am I trying to achieve by doing this? So most of the times that makes it more objective, and that helps us all get on the same page as well. Okay, what is our common goal? What are we trying to achieve? And get to a single answer most of the times. So choice of sedative agent, again, what are you treating? So as we talked about, is more analgesia more of an issue, or more of an amnesia is going to be, or like anxiolytic is going to be a more of a preference in this patient. So that will help you choose that sedative agent. Again, depending on the condition, is it infusion or intermittent? So most of the times we're going to use infusions, but sometimes if the situation demands, we might do intermittent agents. So, and we'll talk about each and every one of them. Some agents are more suitable just with the way they are, the pharmacokinetics are, or the way they are manufactured. They're more for infusions. Some are more for intermittent. And then, coming to pharmacokinetics. So, what's the preferred route, how we give them? I mean, most of them are going to be IV, but we'll look at a lot of agents have multiple other routes where we can give them, especially when you don't have an IV access. So you want to sedate someone to get an IV access. That can sometimes be an issue as well, especially with pediatrics. So you want to have some idea about what pharmacokinetics, and then either they are renally excreted or excreted from the liver. So most of the agents, either it's two types, bless you. So either they are unchanged, excreted in the urine, so they don't get metabolized at all, and they just go, the kids will just pee it out, or they have some metabolism that happens in the liver, and then they get excreted either through the biliary tract into the stools, or part of it also goes through the kidneys and the urine. So just a simple knowledge, again, we don't need to know each and every one in depth, but okay, if this patient has liver failure, maybe this medicine is going to get accumulated in the system. Not a good choice. Or if this kid is not peeing, is having kidney failure, maybe this is not a good choice. So something like that would help. And always, with everything, I mean, we talk about Tylenol has side effects, Motrin has side effects, right? Oxygen has side effects. So everything is a drug, and whenever we're using a medicine, it comes with its side effects. So as long as we are mindful of what these side effects are, and you might have heard me say, ICU is all about anticipation. So like what wrong can happen, or what could be the complications. If you're prepared for that, you can address them in a timely manner. Okay. So if someone gets morphine, you know that can drop their blood pressure. You know that might have them stop breathing. So when you're giving morphine to a patient who doesn't have a breathing tube, maybe you want to consider, is this a too high dose, or is this patient coming in for, is a trauma coming in for hemorrhagic shock or a septic shock, and you have a borderline blood pressure and you're giving morphine, is this going to drop it further? So with some important side effects, and the common ones, if we remember, I think that would help us watch for them. Sometimes that's the only medicine that you can give them, but as long as you know what side effects can happen, and if you're prepared for that, you can, avoid them. And then one of the most important things that we always want to know is reversal agents. So for some reason, the medicine is just acting like someone got a very low dose of morphine, but they just stopped breathing for a reason, and at that dose they shouldn't be, but maybe their body reacted in a different way. And so how do I reverse this? Because you don't have a breathing tube and someone's not breathing effectively, you want to reverse it. So that's another thing to remember, is there a reversal agent for this particular sedative? And again, when we talk about the individuals, not everyone has a reversal agent, so that could be some limitations. Okay, so coming to the different opioids. So we'll start with opioids. I mean, those are the most common ones that we use. So which are the common ones that you've seen been used? Brittany? Sorry. You're the newbie, so I'm gonna put you on the spot. You just have to name them, so that's it.
What's one of your meds your kids on right now? Oh, they're not on any meds.
Oh, okay. Just some common opioids that you have seen been used. So opioids, narcotics, they're the same class. So oxycodone, yes. But that's more for, so we're talking for opioids more for sedation and not for pain control. You can phone a friend.
Can we answer for her?
Yeah, that's fine. I know. Okay, no, that's
Fentanyl?
fine. Yeah, fentanyl.
Fentanyl.
Yeah. What else?
Morphine,
Morphine. Yeah.
which is the oxycodone in IV form,
Mhm.
of course.
Yeah. Any other than these two you've seen being used? Or you might have heard about that. What's that?
Sedation or pain?
More for sedation. Yeah.
I don't think we used Dilaudid much for sedation, do we?
We can. So yes,
Okay.
yes.
So
Dilaudid
if somebody
is
has an allergy to morphine or
Yeah,
doesn't
absolutely.
respond as well to it, maybe
Yeah.
some of our sickle sellers.
absolutely. I mean, I think when you brought up a very good point, and we'll talk. I mean, I think especially for that is Dilaudid works great. I mean, so it's a PCA, so it's almost like a continuous infusion. So yes. So again, we talked about fentanyl, morphine, hydromorphone, or Dilaudid, and then these are newer fentanyl derivatives. One is remifentanil and one is sufentanil, and we'll talk briefly about them. So these are the most common ones that you will see being used from the opioid class. So the fentanyl, or the ones that end in tenil, are the synthetic opioids, whereas morphine and Dilaudid are more, plant-based. As you know, they come from opium. So why are synthetic opioids so popular? Why is fentanyl the go-to? Because they have limited effects on myocardial function. They're not myocardial depressants. They do not really affect your blood pressure so much. Again, any medicine, as a disclaimer, any sedative in higher doses is going to drop your blood pressure, right? I mean, when your kid is agitated, they're tachycardic, they're hypertensive, so you want to get that down. So it's not that they're not going to have any blood effects, but they're relatively safer than a naturally occurring opioid like Dilaudid or morphine. the beneficial effects on pulmonary vascular resistance. So some kid were worried about pulmonary hypertension, like these NICU grads that we get who are trach men. These are great medicines because they dilate the pulmonary vessels, so they have better oxygenation. They have short plasma half-lives, so they don't really last in the system that long. And that's one of the reasons why continuous infusions are helpful, because you continue to maintain that steady level. The intermittent doses don't help so much. So you might have seen whenever we have an intermittent order like a Q2 PRN, it should always be a sedative order, like a continuous infusion order, because that's how you're going to maintain a fixed amount of sedation. So coming to fentanyl, again, this is the least expensive synthetic opioid. So that's the reason why it is most commonly used, because again, we talk about pharmacoeconomics, that's another thing. Okay, how much is a vial of fentanyl going to cost compared to a vial of remifentanil? So it's very least expensive. It's most clinical experience, almost every ICU, that's like the default sedative med to start with. So there's most clinical experience about effects, side effects, and dosing. It's metabolized by the liver, so you have to be careful for patients who have liver toxicity. Usually, the initial bolus dosing could be 2 to 4 mics per kilogram, and that's usually your dose that you would do for intubating someone. I usually, if you're intubating just with fentanyl and not any benzodiazepine along with it, I would use a higher dose of fentanyl, because you want to make sure that you give more analgesia, you don't have anything to help you. But 2 to 4 mics per kilogram is usually the dose range, and the starting dose usually is 2 mics per kilo. Some kids, especially newborns, are very sensitive, and they might need like a 1 mic per kilo dosing, or not even continuous. They might just do well with intermittent, because newborns really don't, they feel pain, but they don't really need that continuous sedation. One of the bigger disadvantages is rapid tolerance. So the tachyphylaxis is the term for that. And that's what you see, especially if someone's been on sedation for 4 or 5 days, you need this escalation in the dose. They started with 2, and by day 5 on the ventilator, they're up to like 5 or 6 mics per kilogram, because they get adapted. The body gets adapted to the dose very fast. One of the common side effects that you need to be aware about is rigid chest. So what happens is, this is usually common in the younger age group, especially newborns, young infants. A rapid bolus can do this. It's idiosyncratic, so it's not dose dependent. So it can happen even with a 1 mic per kilo dose, and it may not happen with a 4 mic per kilo dose. And basically, you just are not able to bag them or ventilate them. The treatment is neuromuscular blockade. So you just have to paralyze them, so you get rid of that. And that's one of the reasons when I'm intubating someone, I just, I'll and tell the nurse, just it's okay if you give it fast, because you're gonna follow that fentanyl with a rocuronium dose anyways, or any other neuromuscular blocking you're using. So it doesn't matter if it would cause rigid chest, because you're gonna treat it anyways. So it's an immaterial thing. But you have to be careful, especially if you have a non-intubated patient, and if you're using fentanyl for pain control, then you want to make sure that you give a slow bolus and you're not giving it fast. Coming to morphine, so it's extremely effective sedative and analgesic. It has more potency at the mu receptor is the one that we all know, which is the most common receptor for analgesia than fentanyl, it has active metabolites, and these have their own analgesic activity. And that's one of the reasons why morphine is not the most popular medicine for using as a starting medicine for sedative, because what happens is, once you, for example, if you want to extubate someone and they're on fentanyl, and if you stop it, there's a predictable, within 20 minutes, half hour, this medicine is going to wear off and they'll be ready for extubation. The problem with morphine is, especially if they've been on morphine for 2 or 3 days, these active metabolites are going to be in the system, and they're more potent than morphine. So there is no predictability as to when this patient will be ready to be extubated, or that those medication effects will wear off. And that's one of the common reasons why morphine is not the first line of sedative agent for ICU sedation. Again, it's metabolized in the liver, excreted in the kidneys. It can cause histamine release, as we all know. So, especially if you have an asthmatic who is intubated, probably not a great choice to use morphine. And it has less tolerance. And usually when we do a change of opioids, so if someone's on 4 mics per kilo of fentanyl, and if I have to change them to morphine, I usually start at a 50% equivalent dose of that, and there are calculators online that help us do it. So, or pharmacy can always help. So that means that they're not going to need the same morphine equivalent doses of 4 of fentanyl, because it's a different way the receptor sees it. So you can start at a half dose and then inch up if you need it. And it doesn't have, the tolerance potential is much lower than fentanyl. That's why you might have seen when kids are on morphine, they just love it even at a very low dose, compared to fentanyl where you have to rapidly, escalate it. Again, there's venodilation, so it affects your blood pressure. That's one of the reasons why it's not a great agent, especially in the trauma. They usually don't like morphine, especially because if you're bleeding, you're hemorrhagic shock. They would always prefer fentanyl for pain control. So you can do like a small 1 per kilo or half per kilo, mics per kilo of fentanyl instead of morphine. Dilaudid is more potent than morphine, so it's 8 to 10 times more potent. It has similar volume of distribution and duration of action. So usually, I think the peak effect happens within 15 to 20 minutes. Usually up to 90 minutes both last, morphine and Dilaudid in the system. There's no histamine release, so it's an agent of choice for PCA in adolescents and young adults. So as Wendy said, the sickle cell patients are one of the common ones I've seen is, and we don't have those, but if we get a pediatric orthopedic surgeon, like spinal fusion patients, I think those are the patients who need a lot of pain control, and Dilaudid is a great choice. So if you have a young adult who you would think of sedation, Dilaudid may be a better option than morphine. They just tolerate it better. So what is remifentanil? And so this is an ultra short acting opioid. It's a fentanyl derivative. It has a very short half-life. These plasma enzymes that metabolize it, so it doesn't have to go through any liver, kidney metabolism. The pharmacokinetics are not altered by gestational age or chronologic age, so it's great for even preemies, for sedation. And because of its unique pharmacokinetics, it's a great choice for traumatic brain injury patients where you need these frequent neurologic examinations. So you can, if they're on infusion, and the dosing is microgram per kilogram per minute, that's the only one sedative where you do per minute. All of them are per hour because it's a fast-acting medicine, and you can stop it, get a neuro exam, restart the remifentanil. One of the most common things, it's not a very commonly used medicine, so dosing errors can happen, and then if you're giving a very high dose, they can become apneic. So you have to always be cautious. It's usually 1/10 of fentanyl, so 1 microgram per kilogram per hour of fentanyl would be, I would say, 0.1 microgram per kilo per minute of Remi. So that's how I remember it. Again, it's very expensive, so you have to be cautious about using it. So I think at this point, really, the only use where I see remifentanil would be the younger patients where I wouldn't use propofol for these rapid neurologic assessments. So this was an article that got published recently, and I think I forwarded this to Tammy and Mary Jo, and I can forward it to you guys as well. So this was actually at the Children's Hospital of Atlanta in Georgia, and they looked at use of remifentanil for this particular indication. I'm sorry, my bad. This was actually Markall. So this is nationwide Ohio that they used it. He's a big sepsis immunology person. So there's, again, as I talked about, the microgram per kilogram per minute dosing, and the conclusion was that it is a suitable sedative agent for use with TBI, because the other option is propofol, and when we talk about propofol, the reason why, the limitations why we can't use propofol in kids, and that's the reason why this is a great alternative for that. So coming to naloxone, which is Narcan, so that's a reversal agent, and again, the low dose is 1 microgram per kilogram, high dose is 10 microgram per kilogram. So if you find any, young adult or adults who are, we have a code blue situation, I think.
You mean like out in the street? Yeah, that's right.
Or even like
Even
if we get,
a-
yeah, I mean, you're using a restroom and someone has someone just passed out.
Yeah,
I mean,
wonder why.
yeah, and I mean, the first thing you would do is consider Narcan, because you
Yeah.
just, I mean, and IV is the preferred route, and it can be administered IM, intranasal, and sublingual. So I think a lot of police officers, EMTs are getting trained for the intranasal Narcan. They have a special device that they can do it. So if they're responding to a code or a respiratory arrest or something, they're trained. It's a very short-acting medicine. So if someone has overdosed on an OxyContin or something long-acting, you may need 1 more doses of Narcan. So they might just come out and go back into respiratory arrest. So something to consider. I mean, usually patients, when we extubate them and you're like, oh, maybe they have some residual opioid in their body, and then as we all know, the tube is a big stimulus. So once you take that out, they're like, oh, I don't, there's nothing that they have to fight against, and then they don't want to breathe. And then you're like, well, now this is your moment, you have to breathe. So I think, I've used it maybe 3 or 4 times in my 3 years of training. So it is available, but sparingly, but knowing that yes, you can get it, and I'm sure it's in our Pyxis where we can just pull it out. So just consider that. I mean, if someone's been too sedated and doesn't want to wake up.
And that really should be on the MAR for your kids that are getting Dilaudid, PCAs.
Mhm.
Like when we get some kids that come back from the OR, and like these little babies that go down for pylorectomy, this is
Mhm.
our frequent ones that happens to. I mean, how long would you wait until you're like, okay, I'd like to give some Narcan? I mean, how long do you think that?
Or before you have to give another dose of Narcan.
Yeah.
I would say and that's where your half-life is 30 to 81 minutes. So I mean, it can, I would say probably 5 to 10 minutes, and you may have to give another dose, I would say.
So when they come back, if they're still doing this, if you leave them alone, they are apneic, that would be a good time for us to say to the
Absolutely.
hospitalist, like, okay, they're still doing this.
Yeah.
We're, at this point, if we don't touch them, they're not breathing.
Yes, and one of the most common pitfalls that we fall into, and really important for Brittany, for you to understand that, right from the get-go, is, oh, the statin 100%. It doesn't matter. I mean, they're oxygenating but not ventilating, right? I mean, if you're not breathing, you're accumulating CO2, and I mean, a point will come where your CO2 is in 90s and 100s, where it's not allowing any oxygen to come into the alveoli, and then you start becoming hypoxic. So for someone who's not breathing and becomes hypoxic, that you probably missed the boat. So a SAT of 100 for someone who's not breathing is immaterial, because you want to make sure why they're not breathing. So hypoventilation, and that's where your oxygen number, that's why entitled CO2 has come into such an important marker, because your pulse ox is sometimes not enough to tell you what a kid is doing. Yeah.
What would you say?
Hmm?
What?
The pyloromyotomy, the pyloric stenosis ones. Which
We've
is
had
the-
that happen several times, and
They give a big dose.
they give
of
large
fentanyl
doses
down
of
there.
fentanyl
Mhm.
downstairs, and then they're like, oh, we gave them pain medicine, we're gonna send them right on up. It's like, oh, fantastic.
Yeah. No,
You couldn't give them
something to
nothing,
remember,
we'd have been
and
happier.
The other thing with the pyloric stenosis kids is they have so much of metabolic alkalosis.
Yeah.
So you compensate by respiratory acidosis. You actually accumulate CO2. So that can actually affect your ventilation as well, because you don't want to breathe when you're accumulating so much CO2.
Do we know if that's been followed up with? Because these kids are going to PACU, right?
Yes, they go to
How do
PACU.
To do incident reports, so we have a tracking method,
Right.
so that we
I'm
can
not sure, I'd
let
have
them
to
know.
find out, because usually I'm just responding and not their primary nurse, so, either we stand there until finally, usually the hospitals will come in and be like, well, they'll be okay, and I'm like, how long are we gonna keep doing this? Like, I don't think this is okay,
Okay.
but I would get a little nervous about that, you
Yeah.
know?
We do have a Narcan policy. I encourage all of you to review it if you haven't.
And the Narcan dose is always, it's not a very common one, and if you ask me at the, like, just like what's the dose, and I won't remember. So it's always on the code sheet. So if in doubt, always, see your code sheet, and it's always there.
I'm just wondering if maybe we need to grab the end title, put it on them, and then, like.
Yeah, maybe
kind of
have
say,
them on end
This is
title,
kind of like
yes.
what we do, we bring them back, we put them on the end title, and then we start saying, okay, this is how long they're after.
Yeah,
This
like
is
all
what
your
their
end
bias
title is in the
their end
60s
title,
or
this is-
70s.
Yeah,
and
we
you
can
need,
then
yeah.
report it, so that way, once it does reach to a certain level, then the decision's made to
Yes,
give the
yeah.
Narcan. I mean, I understand we don't wanna put the child in pain, unnecessarily, but at the same time,
But I mean, breathing supersedes everything
Exactly.
else. I mean,
Well, so that being said, just like you said, you don't want the child to be in pain, so you're not gonna start at the max dose.
Exactly.
You would start at the
Just enough
smaller
where they can
dose, right,
breathe.
and then bring, and
Yeah.
then you may
well,
have
yeah,
to redose
and I think
it.
sometimes
Mhm.
it's how we're bringing the information to our hospitalists. We're not maybe giving them the right information, we're just saying they're not reading, and we're not giving them all the details.
Yes, yeah, just, I mean, the packaging, yeah,
Yes.
that's always important. So I just pulled up an opioid-induced sedation scale, and I don't know what sedation scale we have that the nurses would chart. The Pacera, oh, okay, perfect. So this is again, it's a universal scale, and so it's great to use in someone who is, especially for a non-intubated patient, I think this would be great. So like someone is on a PC, I think this is a great scale where you can use it and see how they're doing. Any questions about opioids if we go to benzos? Okay. And you guys can always ask questions at the end as well. So again, I'm not gonna bore you a lot with the mechanism of action, but just from anything in the central nervous system that is depressant is like a GABA. If you guys remember from the physiology, it's a GABA mimetic. So it either acts on the GABA receptor and it increases GABA in the system. So it's gamma aminobutyric acid, if you're interested in the full name, and that it's an inhibitory neurotransmitter in the brain, and so that's how benzodiazepines act. That's where the barbiturates act, propofol acts, and all these medicines increase GABA in the brain. So it's great. It causes amnesia. There is sedation, anxiolytic, but it does not give any pain control. So I think that's very important, and that's the reason why you probably don't see anyone just sedated with a benzodiazepine infusion, because there is no analgesia with these. So so one of the common ones that we use for continuous sedation is Versed or midazolam. Again, the reasons it's rapid onset. Within a couple hours, midazolam would act. Again, short elimination half-life. The starting dose is usually 0.05 milligram per kilogram per hour. It's metabolized in the liver, and it has an active metabolite. Again, midazolam is great. It can be given oral, rectal, transmucosal, so you can give it, sublingual, subcutaneous. So it's multiple routes, and it's one of the ideal agents for procedural sedation. IM as well, I think I didn't mention that, but it can be given intramuscular as well. Nasal is another route you can give. The only issue they've found is the nasal Versed can be very, the kids have like a burning sensation, so it's not very comfortable. Coming to Ativan or lorazepam, it's water soluble. It's again metabolized in the liver. But being water soluble, it still has reliable pharmacokinetics. With liver disease, there's no active metabolites. It's it's slow onset, but longer duration. So 4 to 6 hours instead of midazolam, which will stay in the system for 2 to 4 hours. Again, it's your drug of choice for status epilepticus. Again, your anxiolytic dose is more like, again, the same 0.05 milligrams. Sedative would be more like a 0.1 milligram per kilogram. Dose, again, for status epilepticus is 0.1 milligram per kilogram. Again, if you use concomitant, you can reduce your midazolam dosing requirements. So if someone's needing very high doses of midazolam, like you can go up to like 0.3, I think is almost like a lot of Versed. You can put them on scheduled Ativan with a midazolam drip, so you can, so you're not needing a lot more of Versed. One of the reasons why Ativan is not as a drip is because it has this propylene glycol, and especially in infants, the newborns, if you it can accumulate a lot of propylene glycol and cause toxicity. So it's like a metabolic acidosis, like ethanol poisoning or methanol kind of thing. That's one of the reasons why it's not a drip medicine. So flumazenil is the antidote for benzos. Again, the initial dose is 0.01 milligram per kilogram. To be honest with you, I have never used flumazenil. So it's usually benzodiazepine induced respiratory suppression is not as bad as opioids. So they almost, you can reverse them, and you can use incremental doses. Again, lower doses for sedation reversal, higher for overdose. So if someone comes in who took 10 pills of Xanax or something and is not breathing, yeah, maybe. If you don't want to intubate them. And then infusions you can do as well if they need it. But one of the most important thing to remember is you can have risk of seizures. So especially, again, we don't see this population who have benzodiazepine overdose, abuse, but in the adults, I mean, if you give them flumazenil, they can seize because they're used to taking that much benzos. So then the others, I mean, these are the miscellaneous category because they really don't fit into any other class. So can you name some of those that you've seen which don't fit into these opioids? Yeah, so Precedex, yep. So that's dexmedetomidine. What else? Propofol. Something that starts with K. Ketamine, yeah. We talked about barbiturates, so those are sedation. So ketamine, propofol, etomidate, dexmedetomidine, that's Precedex, isoflurane, so anesthetic gases come into this, and chloral hydrate. Yeah, and these are, and it's a very old school medicine. I've probably used it once, and again, and we'll talk more about it. So ketamine is a phencyclidine derivative. So if you look at phencyclidine, what it tells you, it's a hallucinogen, right? I mean, angel dust, PCP. So it's these are your street drugs for for hallucination. So ketamine actually chemically resembles those, and it causes this dissociative anesthesia. So you don't feel like you're dissociated from the pain. It's as if you're away from your own body and you don't feel that pain, that kind of sense. And that's what ketamine does. It does cause amnesia,